Hello, my name is Brad Langford. I'm an antimicrobial stewardship pharmacist with Hotel Dieu Shaver Health and Rehabilitation Center in Ontario, Canada, and it's my pleasure to present to you today on the relevant literature as it pertains to colchicine for the treatment of COVID-19. Colchicine is an alkaloid extracted from the Colchicum autumnale plant. Colchicine is really an ancient drug, potentially one of the world's oldest anti-inflammatory agents, dating back to as early as 1500 BC, where it was used in Egypt for pain and inflammation. In present day, there are a number of indications for colchicine's use. Gout and familial Mediterranean fever are the two key FDA-approved indications. However, given its anti-inflammatory properties, colchicine is also used for pericarditis, and more recent evidence indicates that it can help to improve outcomes for patients with coronary artery disease and acute myocardial infarction. This video will focus on colchicine and its potential role in COVID-19. Its low-cost oral availability and potential impact on inflammation in response to infection does make colchicine an intriguing option. Unlike other agents for the management of COVID-19, the mechanism of action for colchicine is less well described. The most likely mechanism of action lies in colchicine's inhibition of microtubule polymerization. Microtubules are key components of a cell's cytoskeleton and made up of alpha-tubulin and beta-tubulin, which are connected as an alpha-beta dimer. What colchicine does is it forms a complex between alpha and beta-tubulin, thereby preventing microtubule elongation. Colchicine concentrates highly inside of neutrophils, which prevents neutrophil migration, adhesion, and degranulation, important steps in the inflammation process. Additionally, microtubules are important building blocks of inflammasomes, and inflammasomes are proteins found inside of macrophages that are triggered by infections to release a number of pro-inflammatory cytokines. A specific inflammasome called NLRP3 seems to be activated by SARS-CoV-2, and the degree of activation appears to correlate well with the severity of COVID-19. So colchicine might help to work to reduce this innate immune response and the inflammatory cascade and lung injury that follow. There is some evidence that from rat models, this mechanism might hold true. In this recent study, intravenous oleic acid at high concentration was given to rats, which causes lung damage and acute respiratory distress syndrome. Oleic acid, just like SARS-CoV-2, activates the NLRP3 inflammasome. It was found that in rats who received colchicine, there was reduced lung injury, reduced lung edema, and improved oxygenation. The authors also found that lung neutrophil recruitment and activation was reduced in the presence of colchicine. So colchicine seems to have an impact on innate immunity and reduced inflammation, but does colchicine have any direct antiviral effects? In theory, we know that microtubules are needed to support viral cell entry, assembly, and exit, and this is no different in coronaviruses. While we don't have any direct evidence that colchicine has antiviral effects on SARS-CoV-2, molecular modeling studies and animal models indicate that colchicine may inhibit viral activity for other viruses such as Zika, dengue, RSV, and potentially HIV. Now that we know there's biological plausibility to colchicine's effect, let's briefly explore the pharmacokinetics. Colchicine is rapidly but incompletely absorbed when given orally. It is lipophilic and distributes well across most body tissues. As we will see later, colchicine is pumped out of cells by P-glycoprotein, which is lacking in neutrophils, so colchicine accumulates quite heavily in neutrophils. Colchicine is mainly metabolized by the liver and excreted in the feces. However, about 10 to 20% is excreted by the kidney. So renal function is an important consideration, especially for those receiving interacting medications or those with hepatic insufficiency. In terms of safety, you may see slightly different recommendations depending on the source, but these are the general recommendations. Colchicine should be avoided in patients with severe hepatic impairment. And recognizing that the term hepatic impairment alone can be somewhat vague, the recovery colchicine trial that we will discuss later excluded any patients with severe hepatic impairment, which the authors defined practically as requiring ongoing specialist care. It is also recommended that colchicine be avoided for those receiving cytochrome P450 3A4 or P-glycoprotein inhibitors in patients with renal or hepatic impairment. Precautions to consider are the use of colchicine in older adults with reduced renal function and the use of PGP or CYP3A4 inhibitors and those with mild or moderate renal or hepatic impairment. Although cohort studies seem to indicate that there are no teratogenic effects to colchicine's use in pregnancy, and there does not appear to be a signal of harm in breastfeeding, there is some biological plausibility and evidence of harm in animal studies. As such, the manufacturer recommends avoidance of colchicine in both scenarios. Additionally, the randomized controlled trials that we will discuss later, it did exclude pregnant or breastfeeding patients. The adverse effects of colchicine are largely related to its pharmacological effect of impairing microtubule assembly. So there are many potential adverse effects that are dose-related with a particular impact on proliferating tissues. It should be recognized that the therapeutic index for colchicine is quite narrow, and fatal outcomes have been reported in doses as low as 7 milligrams and even lower in doses of 1 milligram daily if the patient has reduced elimination and is on an interacting medication. Toxicity can occur at typical doses, including those doses used for the treatment of COVID-19, but the likelihood and the extent of toxicity depends on factors like the hepatic function, renal function, and the use of interacting medications for that patient. At doses used in the clinical trials, on this slide are the most commonly reported adverse events. Gastrointestinal events are most common, especially diarrhea. Colchicine inhibits the gastrointestinal sodium-potassium ATPase, which results in reduced sodium and water reabsorption. Nausea and abdominal pain are also potential side effects but are less common than diarrhea. Myalgia has been reported occasionally, as well as potential rhabdomyolysis, which is rare but important to monitor for. Hematologic effects are uncommon but are of significant concern. Myelosuppression and resulting leukopenia, granulocytopenia, and thrombocytopenia are possible, especially at higher doses or those receiving interacting medications. With colchicine, we really need to be vigilant to check for drug-drug interactions. Colchicine is a substrate of both the metabolizing enzyme cytochrome P450 3A4 and P-glycoprotein efflux pump, so the use of CYP3A4 or PGP inhibitors can increase colchicine levels and cause toxicity. On this slide is a non-exhaustive list of commonly used inhibitors of CYP3A4 and PGP that we should keep an eye out for. Clarithromycin, which inhibits both CYP3A4 and PGP, is of particular concern. There have been several cases of colchicine toxicity, including pancytopenia, rhabdomyolysis, as well as fatal outcomes related to the co-administration of these two agents. It is important to note that in the largest trial evaluating colchicine for COVID-19, the recovery trial that we will discuss later, patients receiving strong 3A4 or PGP inhibitors were excluded from the study. Dosing of colchicine for patients with COVID-19 has not been established. But here are the dosing regimens used from colchicine randomized controlled trials. Each regimen includes a loading dose or a loading period followed by a maintenance period, and the duration ranges from 10 days to 30 days. Note that patients with low GFRs, usually less than 30 mL per minute, were either excluded from the trial or had a dose adjustment. And in contrast to the doses used in the trials of 0.5 and 1 milligram, these doses are not broadly available in the US and Canada at this time, so prescribers would have to use the 0.3 milligram or the 0.6 milligram doses instead to make up doses similar to the ones used in the trials. There currently is no available liquid solution for colchicine, but the tablet can be crushed and dispersed in water if needed. A few patient counseling and monitoring points for those who do end up receiving colchicine It's important to warn patients for the potential for drug-drug interactions, as well as to report any signs of toxicity, particularly neuromuscular toxicity, such as any new or unexplained muscle pain. If doses are missed, patients should be instructed not to double up on the next dose to reduce the risk for toxicity. Also keep an eye out for any hematologic toxicity, so complete blood counts should be checked at least weekly. But not to get ahead of ourselves, we need to know if colchicine actually has an impact on COVID-19. This table summarizes the main studies done to date, arranged in order of study design and patient sample size. Recognizing that there are significant limitations to the smaller observational studies, including the potential for selection bias and unmeasured confounders, we will focus on the randomized controlled trials towards the bottom of the table. There does appear to be a potential benefit for colchicine in hospitalized patients with COVID-19 in terms of the need for oxygenation, as well as the WHO Ordinal Scale for clinical improvement. But these inpatient studies by Lopez and colleagues and the Greco 19 study are relatively small. The Greco study was open label, and so there is some uncertainty regarding the reproducibility of these findings. The ColCORONA trial, on the other hand, focuses on colchicine use in outpatients and has a much larger sample size, looking at clinically important outcomes, including mortality. So let's focus a bit closer on the ColCORONA trial. A word of caution, though, is at the time of this video, this study is only available as a preprint and as such has not been peer-reviewed yet. Nevertheless, this trial is a large, randomized, double-blind, placebo-controlled, multi-center trial. It focuses on outpatients over the age of 40 who were enrolled within 24 hours of a COVID-19 diagnosis. Patients had to have at least one high-risk factor, which the authors include as age over the age of 70, a number of chronic conditions, as well as criteria based on signs and symptoms, such as the white blood cell count parameters and fever over the temperature of 38.4 Celsius. The intervention was colchicine 0.5 milligrams twice daily for 3 days, and then 0.5 milligrams once daily thereafter for a combined total of 30 days. Patients were randomized to colchicine or a matching placebo. The primary outcome was a composite of death or hospitalization for COVID-19 in a 30-day follow-up period, and the secondary outcome was the need for mechanical ventilation within 30 days. Unfortunately, the ColCORONA trial was stopped early. It was only at 75% target for enrollment at the time that it was stopped. The authors indicate that this was due to staff resourcing challenges, variable recruitment rates that ebbed and flowed with the COVID-19 waves, and a desire to communicate the results early so that it could potentially impact treatment for patients globally. So the study enrolled 4,448 patients. However, due to test reagent shortages early in the pandemic and the fact that some patients were diagnosed based on symptomatology and epidemiological links alone, 4,159 had PCR-proven COVID-19. Patients were enrolled and randomized at a mean of about 5.3 days after their symptom onset, and their treatment duration was on average very close to the target of 30 days. Baseline characteristics of study patients were well balanced, except for one key difference was that there were more female patients in the colchicine group than in the placebo group. So let's look at the study outcomes in the intention to treat and the PCR-proven populations. 4.7% of patients receiving colchicine were hospitalized or died within the 30-day period, compared to 5.8% of those receiving placebo. This results in an odds ratio of 0.79 with a 95% confidence interval that just crosses 1. All of the other point estimates for the clinical outcomes did favor colchicine. However, the confidence intervals were relatively broad and crossed 1 in the intention to treat population. In the PCR-proven patients, they had similar outcomes, but for the primary outcome, the confidence interval did not cross 1 and was a statistically significant finding of a reduced risk of death or hospitalization with an odds ratio of 0.75 and a 95% confidence interval of 0.57 to 0.99. This primary endpoint was largely driven by by hospitalization, as the event rates for death were quite low. So if we look at the numbers needed to treat, colchicine would need to be administered to 84 patients for 30 days to prevent one hospitalization. That's from the intention to treat analysis, and slightly lower at 72 patients if looking at the PCR-proven patients only. So for the primary outcome of hospitalization or death when stratified, you see that colchicine seems to be associated with lower event rates across most groups. Of interest, however, is the difference between males and females, where females seem to derive no benefit from colchicine therapy. The reasons for this finding are not clear, but it's important to note when interpreting these results, especially considering that there were slightly more females in the colchicine group. This will also be important and interesting to examine when looking at future studies of this agent. So for adverse events, on first glance, it appears that there are more serious adverse events in the placebo group, which would seem counterintuitive. However, the authors included pneumonia as a serious adverse event, which is essentially what colchicine is aiming to prevent. So pneumonia is probably more suitable as an efficacy outcome rather than a safety outcome for this type of study. But looking at the other side effects that were more frequent in the colchicine-treated patients, we find that pulmonary embolism occurred in 11 patients on colchicine and 2 patients receiving placebo. These were small numbers, but did result in a statistically significant difference and is cause for some concern. The more commonly expected adverse drug events were gastrointestinal, specifically diarrhea. So when looking at these adverse events and calculating the numbers needed to harm, with a number needed to harm of about 250 for pulmonary embolism and a number needed to harm for about 16 for diarrhea, contrast that with 72 to 84 for the efficacy outcome on the previous slides. The risk to benefit ratio may not necessarily be in favor of colchicine in this population. Upon reflection for limitations of this trial, one potential perceived conflict of interest is the fact that the institute for the study holds a patent for the 0.5 milligram dose of colchicine, which is, as we've seen earlier, a unique dose that is generally not available in the US and Canada. Another key concern is that the study ended early, which really compromises the statistical power and as such our ability to draw firm conclusions from these data. As previously mentioned, this is a preprint, so we should take this with a grain of salt while we await the peer-reviewed publication, which is anticipated soon. And with a study like this, readers would expect to see a survival curve to get a better understanding of the temporal impact of colchicine on the study outcomes compared to placebo. Some experts have also criticized the long study duration of 30 days, which likely extends the risk for patients but probably doesn't extend their benefits, as many patients will recover long before the 30-day period. But of course, there are more data to come. A look at the clinicaltrials.gov website indicates that there are 26 interventional trials using colchicine for COVID-19, with 17 recruiting and 3 completed. The most anticipated trial for colchicine is the recovery trial in the United Kingdom. It is estimated that the recovery trial will randomize at least 5,000 hospitalized patients, making it the largest trial to date looking at colchicine for COVID-19. The dosing in the recovery trial is colchicine 1 milligram followed by 0.5 milligram 12 hours later, and then 0.5 milligrams twice daily for a total of 10 days. And since these are hospitalized patients, the risk for negative outcomes such as mortality will be higher. So if colchicine has a definitive impact in this population, this study should be well powered to look at the 28-day mortality endpoint, as well as the secondary outcomes, including duration of hospital stay, composite of death, and need for mechanical ventilation or ECMO. So in summary, colchicine is an inexpensive and widely available oral anti-inflammatory agent that may also have some antiviral activity. However, based on initial studies, the degree of benefit and the optimal populations for colchicine in COVID-19 are uncertain. So as such, we currently don't know colchicine's place in therapy, if any. Colchicine also has a narrow therapeutic window, so its risk for side effects and drug interactions is considerable, and is certainly a key drawback to this agent. But additional studies are underway to help us better understand the benefits compared to the risks of colchicine for the treatment of COVID-19. So that concludes the video. Please feel free to reach out to me with any comments or questions. And I'd like to thank you for your time and also for your efforts to support improved care for patients with COVID-19.